Very good morning, Arnob. Can you hear me? As well as So we all are ready. We'll be starting right now. Arnab, can you hear me, Arnab?
Yes, sir. Sir, yes, sir. It is
Hello,
already
Arnab, can you
live.
hear me?
Yes, sir. I can hear you. Hello. Hello.
Anybody from the digital infomedia? Hello?
Hello.
Ranjan, everybody can hear you.
Yes, fine. So now please start Facebook Live. Srikumar, are you ready?
Yeah.
Yes. So, okay. Srikumar, over to you.
Good morning, everybody. As we all know that the world is passing through a very unprecedented event, that is the pandemic COVID-19, and we need to amass knowledge so that we can deal with it effectively. So under the prevailing circumstances, this Sunday Samvaad is a very relevant one where we will be enriched by the deliberations of the speakers and which will make us more knowledgeable regarding COVID-19. The West Bengal State Branch of Indian Psychiatric Society takes this opportunity to welcome you to this program and be a part of it. Thank you.
I would like to request Dr. Professor Vidyadhar Vadve sir, the chairperson of today. I would like to request Dr. Kaustav Chakraborty, Honorary State Secretary of IPS West Bengal State Branch, to welcome Dr. Vidyadhar Vadve sir.
Welcome, Dr. Vadve. Dr. Vadve is a senior consultant psychiatrist based in Pune. Sir has been the ex-president of Indian Psychiatric Society and a very knowledgeable academician. Welcome, sir, as a moderator of today's program.
Thank you. Thank you for very good words. Yeah.
Please ask Dr. Gautam Shah, Vice President cum President-elect of Indian Psychiatric Society, to give his introductory remark.
Gautam Da is here.
Hello. Good morning.
Gautam Da will do the context setting of today's program. Today we'll be discussing on COVID pandemic and its neuropsychiatric aspects, as well as the role of melatonin in the treatment of COVID. Gautam Da, over to you.
Yeah. Thank you, Kaustav. It's a really great initiative by West Bengal State Psychiatry. Thanks to our President, Dr. Sikumar Mukherjee, our Secretary, Dynamic Secretary, Dr. Kaustav, and also the immediate past Secretary, Dr. Ranjan Varchas, for taking this initiative. Yes, what Dr. Mukherjee said, it is we are passing through a pandemic state. We know that COVID is a viral disease, COVID-19, but still it has got so much complication of related to mental health issues. In fact, from Indian Psychiatric Society, we have done studies also regarding this. There are lots of studies. Most important that what are the mental health issues associated with it. We have seen that depression is almost 9.5%, anxiety disorder is 38.5%, depression and anxiety is 40% and more, and moderate level of stress is associated of almost 3/4 of the general population. So today we will discuss regarding the COVID and the mental health issues. Initially, the Amrit Pattajoshi will discuss on role of melatonin in COVID-19, and then Dr. Ranjan Varchas will tell us about the psychiatric manifestation of COVID-19, and after that, our senior past president of Indian Psychiatric Society, S. Nambi, will tell the impact of COVID-19 on pandemic mental health. Today we are lucky to have among us Dr. Vidyadhar Vadve, the past president of Indian Psychiatric Society, who will moderate this session. Thank you so much. With this, I want to stop here, and I request to moderator, I hand over the mic to our moderator, respected Dr. Vadve, sir.
Thank you, Dr. Gautam. First of all, I am really grateful for choosing me to chair this session titled Sunday Samvaad. And it's a great initiative by the Indian Psychiatric Society, West Bengal State Branch, the President, the Vice President, the Secretary of the State Branch. I'm thankful to all of them. And so also to our speakers who are going to discuss. Gautam has already set the ball setting. He has told you about the context. We know there were too many discussions on COVID-19 related issues. But today, as a psychiatrist, we are, as Gautam has said, we are interested in the neuropsychiatric manifestations. So the three speakers are going to tell us about sleep, melatonin, and COVID-19. Then next speaker will be discussing the neuropsychiatric manifestation. And lastly, our ex-former President Sambi will tell us about the public impact on the public mental health. So with this, I'll first request Dr. Amrit Pattajoshi to start his presentation. I'm sure Amrit doesn't need much of an introduction. We are seeing him every Thursday in the Thursday Musing program, and he's the moderator of that program. It's a very dynamic young psychiatrist, and only last year he has become a direct council member of the Indian Psychiatric Society, EC. So he's a direct council member, very active, and we are all going to meet him again in Bhubaneswar. So without much ado, I'll request Amrit. I have heard him speaking on many occasions. He's an excellent speaker. Over to you, Amrit. Please start the presentation.
Thank you, Vatve sir, for your kind introduction. Thank you so much. First of all, I would like to thank West Bengal State Association, the President Dr. Sri Kumar sir, the Secretary Dr. Kaustav Chakravarti, Dr. Gautam sir, and Dr. O.P. Singh, my gurus in IPS, and Dr. Ranjan Bhattacharya for inviting me. So when I saw the flow of the talks, I thought that my topic should not be COVID, the role of melatonin in psychiatry. So I have transgressed, and because we all know what is the role of melatonin in psychiatry. But if you look at the current guidelines for the treatment of COVID, the role of psychiatrist has been incorporated to it. So COVID treatment has been more based on speculations, trial and error, and somewhere I think we are getting a lot of cases where people are complaining of lack of sleep, fatigue, irritability, and somewhere we were considering melatonin as an important part in the arsenal in terms of if you ask people how best to get out of it, eat well, sleep well, and exercise. That's what they tell. So maybe melatonin has a role beyond its effect on sleep. So I have just tried to deviate a little, not talking on the neuropsychiatry aspects, talking more about the other aspects of melatonin, because when I got the topic, it was COVID-19 and role of melatonin. So if I don't dwell too much into psychiatry, please excuse me. So my presentation has been very gross, and it's been a little superficial because of the time constraints. So thank you so much. I'll start again. So COVID and role of melatonin, that is what the topic has been given. So if you look at COVID and its impact on mental health, a lot of uncertainty, helplessness, lack of options, drugs, guidelines, ever changing. Every week, something or the other is changing. Anybody comes out with something, suddenly you find a lot of interest in those molecules or change, and then after 1 month or 2 months, it disappears. So my topic is COVID-19 and melatonin. So melatonin uses in psychiatry and COVID-19 and melatonin. That is how it has evolved. So if you look at melatonin, it was basically Aaron Lerner who discovered this hormone in 1958. It's chemically N-acetyl-5-methoxytryptamine. It is a naturally occurring compound found in all living creatures from algae to human at levels that vary in daily cycles. It is also known as the hormone of darkness. It is secreted in darkness in both day active, that is the diurnal animals, as well as night active or nocturnal animals. These are the various food sources of melatonin. It is not just that melatonin, you only take pills of melatonin. You get a lot of food items from which melatonin we can get, from oranges to berries to bananas to pineapples to corn to almond. So production. In higher animals, melatonin is produced by pinealocytes in the pineal gland, which is located in the brain, and also by the retina, lens, and GI tract. It is naturally synthesized from the amino acid tryptophan, and melatonin produced in the pineal glands acts as an endocrine hormone since it is released into the blood. By contrast, melatonin produced by the retina and the GI tract acts as a paracrine hormone. Production of melatonin by the pineal gland is under the influence of the suprachiasmatic nucleus of the hypothalamus, which receives information from the retina about the daily pattern of light and darkness. It mainly gets stimulated by darkness. Melatonin may also be produced by a variety of peripheral cells such as bone marrow cells, lymphocytes, and epithelial cells. Usually, the melatonin concentration in these cells is much higher than that found in the blood, but it does not seem to be regulated by the photoperiod. Secretion, it generally starts at 3 to 4 months of age. Peak levels are at 1 to 3 years of age, and slightly lower levels through early adulthood. Peak levels for 70-year-old is 1/4 of levels for young adults. So maybe if you are a little older person and you might require high doses of melatonin. And highest levels measured between midnight and 8 a.m. So if you look at the highest measures, it is between midnight and 8 a.m. But as the night progresses to morning, the melatonin secretion reduces. Metabolism, where is it actually metabolized? Liver is the first site for metabolism and clears greater than 90% of circulating melatonin. Melatonin is first hydroxylated and then excreted in urine as sulfate and glucuronide conjugates. And about 1% of melatonin remains unchanged in urine and saliva. So 90% is metabolized in the liver, 8 to 9% is hydroxylated and excreted in urine, and 1% remains unchanged. This comes out in urine and in saliva. So are the various melatonin receptors. They're basically found in the central nervous system and peripheral tissues. In brain, MT1 and MT2 receptors are found in the membranes of neuron of SCN. MT1 and M2 are G protein coupled receptors, and MT3 receptors are also found, which is poorly understood. These are the melatonin receptor agonists. So MT1 agonist promotes sleep via the MT1 receptor in SCN, regulating the sleep-wake cycle, and then we have physiological sleep. So this is the biosynthesis of melatonin from tryptophan to 5-hydroxytryptophan to serotonin. From serotonin via serotonin N-acetyltransferase, it becomes N-acetyl serotonin, and via HYOMT, it becomes melatonin. So light dependency is one of the most important characteristics. Production of melatonin is inhibited by light and permitted by darkness, also called the hormone of darkness. Its onset called the dim light melatonin onset, also known as DLMO. Secretion in blood again peaks in the middle of the night. It's principally blue light around 460 to 480 nanometer that suppresses melatonin. So the blue light in the light suppresses melatonin, and once the blue light reduces, melatonin secretion starts. So use of blue blocking goggles the last hours before bedtime is advised for people who need to adjust to an earlier bedtime, as melatonin promotes sleepiness. So when you have this jet lag and all, you can always suggest your clients to use blue blocking goggles that might induce sleep earlier than what they were having when they change time zones and all. So physiological role of melatonin, it acts as an antioxidant, it acts on the immune system, prevents some cancer, dreaming, sleep, mental illness, it has menstrual benefits, and it has a lot of benefits. So today, I'll be mainly focusing on the antioxidant immunomodulating activities of melatonin. Because when we are prescribing melatonin to a patient, we can always talk to the treating doctors about what are the other roles. Maybe in terms of antioxidant, you're talking about zinc, you're talking about vitamin C. Why not talk about melatonin, which has a much bigger impact, we have scientific knowledge about it, and we have evidence for it. So direct antioxidant actions. It's a free radical scavenger of ROS, free radical scavenger of the RNS. Indirect antioxidant actions in terms of stimulation of antioxidant enzymes, stimulation of synthesis of glutathione, which is a very, very important antioxidant. It has synergetic actions with classified antioxidants in terms of zinc and all also. It scavenges O2 radicals, H2O2, hydrogen peroxide also it scavenges, and it also scavenges singlet oxygen, which create a lot of oxidation damage. So indirect antioxidant actions of melatonin is by glutathione. It stimulates the rate-limiting enzyme glutenyl cysteinase synthetase, thereby increasing the intracellular glutathione. The stimulation of glutathione synthesis by melatonin could be a major antioxidative action of melatonin. So glutathione synthetase hormone, it acts on them and increases the glutathione level. That is an important aspect by which melatonin acts. The other roles of melatonin as an antioxidant, it's a powerful antioxidant with particular role in the protection of nuclear and mitochondrial DNA, whereby it might be having a anti-cancer effect also. Melatonin that can protect against cancer by eliminating free radicals. It is a direct scavenger of OH and NO. The antioxidant activity of melatonin may reduce damage caused by some types of Parkinson's disease and may also play a role in preventing cardiac arrhythmia. Even if you look at COVID, a lot of people we see are dying of viral myocarditis, cardiac arrhythmias. Again, we have a molecule which might help in preventing cardiac arrhythmia, and it does by activating the cytokine system. Melatonin in mental illness, I'll just be giving a passing reference, nothing, because the presentation is little less, we have less time, so I'll be just giving a passing reference. So melatonin is related to mental diseases like anxiety, depression, schizophrenia, phobia, autism, ADHD, and has a quick and lasting effect. Melatonin and depression. Depression is closely related to melatonin. Melatonin biosynthesis and secretion are mainly regulated by norepinephrine. Again, we know the role of norepinephrine in depression. And melatonin level might be used as an effective indicator of the diagnosis of depression. Many times we get people ask us about evidence that somebody has a disease. And disturbed sleep and circadian rhythms is a prominent feature of depression, and altered melatonin secretion has been observed in major depression. And shift workers, an abnormal melatonin secretion has been reported to cause several severe psychiatric disorders. Again, bipolar disorder, look at bipolar depression. Again, melatonin. We can use melatonin to treat sleep-wake cycle disorders, stabilize mood. So basically, the problem is manic episodes among adults. Anti-manic effects have led to some controversy. So if whether it is useful, whether it is not useful. Regarding depressive episodes among adult disorders with among adults with bipolar disorder, there is no specific data concerning an antidepressive effect. Melatonergic agonist would help decrease by half relapses after 24 weeks among patients with bipolar disorder in remission and with persisting sleep problems. So there are some studies which speak about that. Seasonal affective disorder. Melatonin could have an antidepressive effect on seasonal affective disorder associated with significant phase shift if it is administered according to the advanced or delayed phase profile. So if you look at melatonin in SAD, it has a good role. It is important to remember that light therapy remains the reference treatment for seasonal affective disorder, and that melatonin can be used as an adjunctive treatment. So as an adjunctive treatment is good. For schizophrenia, we have patients with insomnia, benzodiazepine withdrawal, delayed dyskinetic movement disorders. Melatonin has a role. In metabolic syndrome, it can have a beneficial effect on certain cardiovascular parameters. ADHD, a delay in melatonin secretion was observed in adults with ADHD and insomnia. And there was a randomized controlled trial carried out on 105 children suffering from.
Let me try one thing. I am just leaving and joining again. Just a minute.
Okay. No, he's joining again. He's not here.
Uh, Again, it is showing that my screen has been paused. So what I'm doing is that I'm sending my slide to Kaustubh. I've already sent the slide to Kaustubh. Can you share the from your end?
Just a minute.
Ranjan, you can send the slides to me. I will share if you want.
Yeah, I'm doing that. Yeah, but my connection is very slow.
Whom to send? Dr. Vidyadhar Vadve, sir?
No. Dr. Amrit is saying you can send the slides.
Okay. Just a minute. I'll send it to Dr. Amrit.
WhatsApp में?
No, in mail.
I'm also trying. Yeah, I think I will do it. No need. I will do it.
Okay, thank you so much.
I will do it.
Have you received the slide?
Yeah, it's almost done. Just wait. Just wait. You made it in PowerPoint 2010? No, I have got it. I have downloaded it. But it is saying that the screen you are sharing is invalid.
Just a minute.
You cannot start. You stop your screen sharing. It is showing.
I think my slide is now showing. Is it visible?
Yeah, it is now visible. Yeah.
Thank you so much.
It is now visible. Yeah.
Change the window.
Okay.
Okay, fine. So sorry about this technological delay. There is something are not in our hands. Extremely sorry for that. So I'm continuing from the presentation where I've left. So about the current health priorities of the COVID and the containment of the, as I mentioned, that the fatigability is out of proportion. The initial symptoms are pulmonary symptoms, but since it has also affiliation to the other system and it's the neurotropic virus, later it has been proved that it is causing the various CNS symptoms and which is affecting our day-to-day life, worsening the quality of life and increasing the morbidity. So there are neuropsychiatric symptoms which can range from 4 to 30% in different scenario. And as you know, the 81% of the cases have remain asymptomatic. The 14% will have the mild symptoms, and the 5% will require hospitalization with the 2% mortality. These 5% patients who are admitted in the CCU or in the SARI ward, they are having the more symptoms and especially related to the central nervous systems. So I will now go through certain case reports that has come in various publications in the literature. In first publication, a man has been diagnosed with SARS-CoV positive and presented with the altered sensorium for the 14 days. And there are signs of meningeal irritation and plantar was extension. And as we then soon send the patient for the CSF testing, and then the CSF testing for the viral strain has been done, and CT scan has been found to be normal. And CSF testing and the CT scan both come to normal with the patient having some meningeal symptoms with the plantar extension and signs of encephalitis. So probably it points that it could be a direct effect of the SARS-CoV-2 to the CNS, not due to any other secondary cause, as there we had negated the iatrogenic use of the psychotropic drugs also. The second case, these three cases have been published in the Asian Journal of Psychiatry, Frontiers of Psychiatry, and the Lancet Psychiatry, these third, fourth, and fifth references. So the second case is from the Lancet Psychiatry, that 41-year-old lady presented with the fever, headache with new onset of generalized seizure. And initially she was diagnosed to have that viral meningitis. And during hospital stay, patient had developed the delirium, the altered sensorium, visual hallucinations, and the extreme lethargy. Then we have ordered for the SARS-CoV test, and COVID-19 test come out to be positive. And CT without contrast was done, and it has come to be negative, and the CSF protein finding the glucose level is normal, and psychotropic drug use has not been found. So again, these symptoms, the CNS symptoms, with the negative ruling out the all other secondary causes of the of infection, it has been indirectly proving that these symptoms are attributed to the SARS-CoV-2. The final case that has been described in the Frontiers of Psychiatry, the 38-year-old lady with no past psychiatric history had presented with the acute persecutive delusion. There's a reaction, the brief psychotic disorder with auditory and visual hallucination and circumstantial speech. And she responded very well to the quetiapine at a dose of 400 milligram per day. Though the patient has been, literature has been reviewed with that the patient had been prescribed the clonazepam, but we do commonly not prescribing the benzodiazepine like this. As mentioned by my previous speaker, melatonin is generating a very good response, and especially it will be very difficult to assess the sensorium if the patient is given the benzodiazepines, and the patient, it may aggravate the respiratory symptoms. In many cases, the patient is having saturation is falling below 93%. It will be very dangerous to prescribe the benzodiazepine in these cases. So this case, all the three cases are pointing that the primary infection of the SARS-CoV-2 can have different mechanism like the HIV/AIDS. As we know, the HIV/AIDS symptoms are responding dramatically to the highly active antiretroviral therapy, heart therapy. Similarly, since there is no specific therapies available, so the CNS symptoms and manifestations occurring in COVID-19 has a peculiar basis and could be directly attributed to the virus itself. So the mechanism, it has been that we all know that the usual cellular route in viral binding to the specifically angiotensin C enzyme receptor, which is widely distributed along the respiratory and GI epithelium. The spread of the CNS has been correlated with the increasing age, the person who is having the high viral load, poor immunity, mentioned by my previous speaker, and administration of the corticosteroid with history of neurotrophic viral infection in the past and increased hospitalization. So these factors are very extremely important for the CNS spread of the SARS-CoV-2. The initial viral spread is hematogenous. In rodents, the virus has been detected in olfactory bulb for up to 4 days after nasal inoculation, and it has been found in the piriform cortex. In other studies in the same group, the destruction of the olfactory bulb has been found, which destruction of olfactory bulb prevented the neural dissemination. So the patient, if the olfactory bulb is being disconnected, it is not spreading further. It showed that the neural proliferation can happen in the cells of the cortex, hypothalamus, and the subcortical structures, and thalamus, emotional circuit, Papez circuit, basal ganglia, these are all involved. The nucleus of the solitary fascicle in the brainstem that receives the informations from the chemoreceptor to alter the respiratory effort is one of the important signs of viral load. So it has been found in animal studies. So these are the examples, the affection of the SARS-CoV-2 in the particular locations of the central nervous system. As you can know, the thalamic and subthalamic structures and the emotional circuits are all getting involved. So neurological manifest, I divide the symptoms in neurological manifestation and the psychiatric manifestation. Again, the neurological manifestation can be subdivided into central nervous system manifestation and peripheral nervous system manifestation. In CNS symptoms, there are headaches, dizziness, delirium, acute confusional states, encephalitis and encephalopathies, acute cerebrovascular events are being finding. The possible mechanism are due to the hypercoagulable states, neurodegenerative disorders on a long run, and epilepsy case reports are there in the various journals. It has been published that certain predilection of the certain central nervous system, especially the complex partial seizure affecting the temporal lobes, have been described. Now coming to the psychiatric manifestation, again it could be divided into further in acute manifestation and the chronic manifestation. The acute or brief psychotic disorder has been mentioned in the case published in the Frontier of Psychiatry. Just described that mania, exacerbation of the symptoms of schizophrenia, acute stress reaction, suicidality, and the substance abuse. So we psychiatrists is getting the most of the cases. The patients are stable patients on bipolar disorder, schizophrenia, or the other psychotic disorders are getting their symptoms flared up. So this flared up could be due to the psychiatric possible infection of the COVID-19 direct cause, or due to the secondary mechanism like the stress factor or environmental factors, or due to non-availability of the drugs or poor compliances. So the chronic manifestation of the COVID-19 are anxiety disorder and the stress factor, the worried well factor. The worried well factor has also been described in the HIV/AIDS, and we have published with an article in the Asian Journal of Psychiatry about the worried well factor with my co-author Dr. Sushati Shekhar Chatterjee in the Asian Journal of Psychiatry. Then coming to the other manifestation, the depressive disorder, obsessive compulsive disorder, post-traumatic stress disorder, adjustment disorder. And it has also been noticed that the flare up of the symptoms of the autistic traits, autistic spectrum disorders have already also been documented. Now coming to the delirium, each symptoms I would like to describe very briefly. The delirium and confusional stage, starting from impaired sensorium to the frank delirium, which is associated with the older age, pre-existing cognitive decline, comorbidities with and high pulmonary severity, index urinary retention, and constipations. There have been the different cellular mechanisms have been described, like the chronic tissue hypoxia, cytokine storms, the chronic use of the hydroxychloroquine, and also can lead to the chronic delirium. The haloperidol, risperidone, quetiapine, olanzapine has been tried as an effective agent, and melatonin has proven efficacy. Now, acute cerebrovascular incidents, as I mentioned, the most probably the ischemic CVAs are due to the low platelet count and increased D-dimer level. The AC receptor mediated endothelial dysfunction is implicated as the pivotal factors, and the thromboplastin time-based clot waveform analysis or CCWA analysis is a prognostic indicator of the hypercoagulability. And this is a poor bad indicator of the prognosis of the cases. These patients frequently moves to the cytokine storms and going to the hypercoagulable states, and eventually the prognosis is worse. Coming to the encephalopathies and encephalitis, which is associated with the existing psychiatric illness, and the risk factors are old age, high blood cytokine level, and prior cognitive decline. And it is characterized by the somnolence, confusional state, catatonic states, and behavioral alteration as well as seizure. Some of the patients are also developing the hyponatremia or SIADH primarily or due to drug-induced SIADH, secondary causes. Case reports of acute necrotizing hemorrhagic encephalopathies are there, and cytokine storm leading to the chronic encephalopathy have been described. Coming to the dysgeusia and anosmia, the most of the patients are not getting any smell or not getting any taste, and the prevalence can be as high as 12 to 32%, which are associated with the olfactory lining AC receptor involvement, with the destruction of the olfactory nerves and roots and bulbs, and biomarker, which can be taken as a biomarker of the COVID-19, very characteristic finding. Hyposmia, anosmia are proposed indicator for the future neuropsychiatric manifestation and can be associated with post-viral olfactory syndrome. Coming to the neuromuscular disorder, which are associated with the myopathy, neuropathy, the Guillain-Barré syndrome, and one of the typical variant of the Guillain-Barré syndrome, which is known as the Miller-Fisher syndrome. These cases have been reported. Elder age with the prior pulmonary involvement and the prior neurological disorders are risk factor, especially seen in the multiple sclerosis as well as the motor neuron disease. Associated with high viral RNA load and the future risk for the demyelinating symptom, though the longitudinal studies are still awaited. It will take long time to get the reports of the how much demyelination has been done and what are the consequences. Neurodegenerative disorders, there are theoretical risk of Parkinson's-like feature with the proven proliferation of the COVID virus in the basal ganglia. Identical pathogenesis with the same we learned from the encephalitis lethargica, but there are no robust literature support is there. So this area is still in infancy. We need to have some reports, and the mechanism have been proposed with the oxidative stress and mitochondrial dysfunction leading to protein dysregulation and neuronal apoptosis. Epilepsy, the new onset seizure or reactivation of the Latent epilepsy have been found during COVID-19 pandemic. They are associated with encephalopathy and cerebral edema. Remdesivir, lopinavir have proven efficacy, but these days almost all the drugs which are used in the COVID-19, initially we have the landmark study of in the Lancet, there are a solidarity trial, and in solidarity trial, lots of drugs have been proven to be efficacious. But again, after 6 months, we are in the back to the same position that these drugs are not effective, and literature supports. In Asian countries, we found the role of HCQS and ivermectin. But the epilepsy-related factor, the mechanism due to the encephalopathy, direct viral invasion, and probably the symptomatic management is the current order on treatment approach, and it requires further investigation. Acute psychotic disorder, mostly isolated case reports of acute transient psychotic disorder, mania, exacerbation of the existing schizophrenia, which are associated with the high antibody titer, low peripheral lymphocyte count, and treated with the atypical antipsychotics or the typical antipsychotic haloperidol at a very low dose. The preferable antipsychotic is the quetiapine. Remdesivir, GMCSF has also been proven have proven efficacies. Suicidality is a very important emergent factor. The suicidality is absolutely preventable, and we have to, being the psychiatrists and other mental health professionals, should come forward for proper assessment with increased surge in COVID era, which are associated with pre-existing depressive or anxiety disorder. Environmental shift in COVID also has poses the great threat for the suicidality. So we have to assess and treat the underlying disorder, psychological intervention. We have to pick up the high risk group, and we have to provide the psychological first aid or PFA with the targeted intervention. These are the mainstay of the therapy. And chronic psychiatric condition can be new onset or worsening of the prior psychiatric disorder due to the existing stress, environmental factor, non-availability of the psychotropic medicine, because most of the patient in the rural area who cannot attend the OPDs during this lockdown period, and which has flared up their infections and which have flared up their psychotic symptoms. Mostly the anxiety, depression, OCD, acute stress reaction, adjustment disorder, and somatoform disorders are coming in our OPD. And animal model behavioral alteration been found and could be correlated. The animal model of the learned helplessness could be can be explained with the Martin Seligman theory of this depression and the other anxiety and stress related factor. PTSD is common and mostly complex and chronic, related to host immune response. Now, I'm going to the very briefly of the Indian study. This was a study done by us. It was published in the May-June article of the Indian Journal of Indian Journal of Psychiatry about the attitude, practice, and behavior and mental health impact of the COVID on doctors. We have surveyed the 152 doctors, and it has been found that the 34.9% doctors were depressed, having depressive symptoms. We have used the DASS scale, depression, anxiety, stress scale, and it has been found that 34.9% depressed, 39.5% having anxiety, and 32.9% having stress-related symptoms. On the same journal, the similar article by Dr. Chakraborty and Chatterjee have been found, and which has been done on the general population, and our survey has been done in the 152 respondents who are doctors. So the summary of the findings of this, that age and having multiple comorbidities are significant predictive factors. Altruistic coping and sense of greater goal are significant among the doctor community. And we're assessing the psychological impact on general population. The key findings by Chatterjee and Chakraborty et al. Are the socioeconomic effect of this pandemic is expected to last long. And the index survey suggests that worry and sleep disturbances are common among the respondents. This landmark article by the Dr. Dinakaran, Narayana Manjulatha, and Naveen and Suresh Baramat have found that the hypoxic brain injury and treatment options and psychological stress might potentially lead to a wave of neuropsychiatric sequelae. And another important article published in Asian Journal of Psychiatry by Devanjan Banerjee and Biju Vishwanath has found that the risk of worsening neuropsychiatric symptoms are there with use of steroids and other immune modulating measures like IVIG, GMCSF, IV inhibitors might hold promise against neurological effects of the virus. Briefly on the international studies, the international studies done by the Avanithan et group published in the Lancet has found that altered mental state status, encephalopathy, encephalitis, and primary psychiatric diagnosis are occurring more commonly in the younger group of the patient. And the next article published in Brain Behavior and Immunity Journal on the spectrum of neuropsychiatric manifestation, it has emerged that the anxiety, mood disorder, headache, sleep disorder, encephalopathy, stroke, seizure, these are very common findings. And CNS infiltration, cytokine disruption and immune cell transmigrations and autoimmune response are possible etiology. Then other studies also reciprocate the same finding, and relationship between the COVID-19 and the psychiatric manifestation, especially the psychosis, has been described in this particular study published in the Psychology and Behavior and Psychology Research and Behavior Management Journal. So in a nutshell, there are iatrogenic factors also attributed for the COVID-19 related symptoms, and these are the commonly drugs that cause neuropsychiatric manifestation. That could be antiretroviral, antibiotic, corticosteroid, and hydroxychloroquine and other drugs. COVID-19 represents a major challenge in the field of psychiatry, as both the virus and medication used to treat may induce the neurological and psychiatric manifestation. And other than direct side effects, there can be drug interaction. They're very important, as that drug interactions is a possible mechanism, and many drugs are metabolized to the cytochrome P450 microenzyme system with the 2D6 and 3A4 pathway, most of the psychotropic medicines. So we have to be very cautious while using these drugs. As we know that prolongation of QT interval with the use of the hydroxychloroquine and other drugs has to be dealt with very seriously, and with the remdesivir can increase the transaminase level, and valproate should be used with judiciously while prescribing the remdesivir. With the favipiravir, which can cause the QT prolongation, should be used judiciously with the other psychotropics, and ritonavir causes abnormal dreams, agitation, anxiety, confusion. So increased concentration and co-administered drugs, which are substrates of the 3A4 or 2D6 enzyme system, like pimozide, midazolam, triazolam, should be used with caution. Azithromycin, the psychotic depression, catatonia, delirium, aggressive reactions are common neuropsychiatric side effects. So QTC prolongations and the life-threatening torsades pointis or polymorphic ventricular arrhythmias are at risk, and hepatotoxicity is also there. So judiciously, we have to use azithromycin with the other psychotropic medicines like quetiapine, valproate, and other relevant drugs. This is a finding that we have published in the Asian Journal of Psychiatry. So these are the other manifestations. I'm not going into the detail, but the most significant aspect is that the use of prednisolone of more than 40 milligram per day can cause a lots of psychiatric manifestation in the form of depression, mania, agitation, mood lability, and anxiety symptoms. And phenytoin has been shown to increase the hepatic metabolism of steroids and decrease effects on 3A4 and 2C19 substrate, which is very common in Indian population due to weak enzyme inducing activity. These are other symptoms like psychotic scenes, delirium, agitation, suicidality, and personality changes commonly found with the hydroxychloroquine. And we have to be very careful, especially looking for the QT interval prolongation, bundle branch block, AV block, and torsades pointis. And it should not be taken without the prescription or without the supervision of a doctor. Other drugs like interferon, vitamin C, tocilizumab, and convalescent plasma therapy with these neuropsychiatric manifestations there are stray reports, and no significant robust methodological study have been done. Like tocilizumab may cause some positive effect on depressive symptom. Vitamin C has no known neuropsychiatric consequences of the high dose administration. Interferons can cause fatigue, mood disorder, and suicidality, anxiety disorder. And convalescent plasma therapy have been found to be associated with the specific neuropsychiatric, no specific neuropsychiatric effects, but have been reports of the palpitation, respiratory distress mimicking panic attacks. So in the miscellaneous, as you know, the social media infodemic, as I mentioned, is also on rise, which can cause lots of psychiatric, neuropsychiatric manifestation. We, being the psychiatrists, have various role to play. We are doing the routine OPD and inpatient care, as well as we are training the fellow colleagues with the psychological first aids. We are providing the psychological first aids to the quarantine and the isolation wards, also to the family members and relatives. We are managing the primary psychiatric disorder, as well as we are also managing the new psychiatric illnesses, relapses, and recurrences, monitoring the adverse drug reaction and treatment emerging adverse effects. We have multiple role to play. Also, with the advent of the telepsychiatric guidelines, we are doing that in-person teleconsultation. So everything has not been locked down. Some processes are ongoing. Childbirth process is one of them. We have to encounter and we have to face the stress symptoms in our day-to-day life, especially during the COVID pandemic. So there are eustress and distress. We are not going into detail, but hypostress is an important factor, which is the lack of state working in the understimulating environment, whereas the hyperstress is two-way negative stress that comes when a person is forced to undertake or undergo more than he or she can do. we are facing the common stressor. We have surveyed in various quarantine centers and found that among the patients who are admitted in the quarantine centers have fear of infection. The duration of quarantine is directly related to the symptom frustration, and inadequate supplies of the medicine or other key things are causing more stress among them. Just a picture of that, you can see the bed distance among the two beds have not been maintained, as well as the quality of the foods and other amenities are not there in psychotropic system that is visited by the team of us. So initially we had the less number of COVID cases with more fear, but as the cases of COVID are increasing, we are encountering less fear. So we are also learning that from the stage of fear, we are in the stage of learning. Now we are in the stage of growth. And my take-home message of this presentation will be that is the only tough time that brings one's true inner self outside. And lots of uncertainty, speculations are surrounding all of us right now. It is not only the COVID-19 which is only contagious, it is also our prejudices, stigma, and our negative thought process are highly stigmatized, are highly contagious. It is easy to start a cycle of fear, misinformation, and apprehensions. So we have to stop doubts, pessimism, cynicism, shaming, fault finding, and blaming others. We have to rise above all the religious, national, political, and social interests. So try to be a role model and accept more and discriminate less. So my final comment that remember the fundamental law of protection. Consider everybody surrounding you as asymptomatic carrier of COVID-19 and capable of infecting you. Consider too that you are yourself could be an asymptomatic carrier of COVID-19 and capable of infecting all surrounding you. So train yourself by using all your intelligence to neither get infected and not infect others. Thank you very much for my patience hearing. Thank you very much.
Thank you. Thank you, Dr. Ranjan, for such an excellent presentation with help of beautiful slides and covering the entire spectrum of neuropsychiatric manifestation of COVID-19.
Sir, start your video. Sir, put on your video.
I will.
Thank you, sir.
Now, I think, am I visible?
Yes,
yeah.
sir.
Yeah.
Yes,
Thank you,
sir.
Ranjan. Thank you again for excellent presentation with the help of beautiful slides and covering the entire spectrum of neuropsychiatric manifestation of COVID-19, including in the end, giving us all the national and international studies of COVID-19 which have appeared in the recent past. And in the end, and you ended with the message, accept more, discriminate less.
Yes.
So with that, I definitely feel that you need to be congratulated for this excellent presentation. I think we will, because of time constraint, we'll go to the last speaker, who is none other than Dr. Nambi,
Sir,
who is a senior psychiatrist from...
Sir, may I interrupt for a while? Sir, Dr.
Yeah.
Nambi is ill and he's admitted in the hospital, so he's not there. If you permit, sir, I can speak for 3 to 5 minutes on his topic.
Please,
I can fill in the gap for him. Okay?
Please. I hope he recovers well. Yes.
Thank you, sir.
Yes. He's been diagnosed with acute pancreatitis and he has to rush to the hospital. He sent a message for that. Okay, sir.
Oh, wish him a speedy recovery. Definitely we are with him.
Yeah.
So, with Dr. Wadhwe sir's permission, I would like to speak for a few minutes on impact of COVID-19 on public mental health. I don't have any slides because I didn't get the time to make any actually. I will just say a few things actually. COVID-19 pandemic, this has been going on for the last 10 months or so. In India, it was, the first case was detected in February, I think. So it has jeopardized mental health services as well as services for other physical ailments because all the resources and funds have been directed towards the treatment of COVID-19 patients and post-COVID complications, health complications. And because of the lockdown, because of the unavailability of local public transports like local trains and other buses, the mental health services have been jeopardized beyond any doubt because the patients were not able to come to the OPDs. The OPD attendance drastically fell, and the district mental health program, of which we are also a part, that was severely compromised because the doctors could not go to reach the outreach camps. The patient could not come to those outreach camps, and in the initial few months of the pandemic, the few of the medicines were not available in the pharmacy shops. Uh, the patients stopped their treatment on their own because of discontinuation of the medications. They had discontinuation symptoms or relapse or recurrence of their current psychiatric conditions. So all these things happened, and these things severely compromise the mental health care of the uh, patients, those are living in the community, as well as those who are living in mental health setups, be it in GHPs or mental hospitals. The mental health services, what WHO has found out, that the mental health services have been compromised in almost 93% of the countries worldwide, while the demand for mental health is increasing because of all the reasons Dr. Ranjan has just spoken about, the neuropsychiatric manifestations of COVID and all those things. And the pandemic is increasing. There is no sign of decreasing or plateauing of the pandemic. The demand for mental health services is also increasing. There is bereavement, isolation, loss of income, and fear, which are triggering mental health condition or exacerbating the existing ones. Many people are facing increasing level of alcohol and drug use, insomnia in particular, anxiety, somatization. So all those are on the rise. And meanwhile, COVID-19 itself can lead to neurological and mental health complications such as delirium, agitation, stroke, executive dysfunction. People with pre-existing mental, neurological, and substance use disorder are also more vulnerable to SARS-CoV-2 infection, and they may stand a higher risk of severe outcomes and even death. So these are the few worrying things during this COVID pandemic. WHO conducted a survey between June to August 2020 among 130 countries across WHO's 6 regions, and they came up with certain startling findings. The countries reported widespread disruption of many kind of critical mental health services. Over 60% reported disruption to mental health services for vulnerable people, including child and adolescents, older adults, and women requiring antenatal and postnatal services. More than two-thirds, that is around 60% saw 67% saw disruptions in counseling and psychotherapy, 65% to critical harm reduction services, and 45% to opioid and agonist maintenance treatment for opioid dependence. So all those things were jeopardized and exacerbated the existing psychiatric or drug dependence problems that were existing in the patients. More than a third reported disruption to emergency interventions, including those for people experiencing prolonged seizures, severe substance use withdrawal syndrome, and delirium, often a sign of serious underlying medical condition. So these are the findings, and 30% reported disruption to access for medication for mental, neurological, and substance use disorder. This is what I was talking about, because in the DMHP district mental health program, we also supply free of cost medicines, and patients come to the OPD once a month, and we dispense medicines to them. So all those things were disrupted during this pandemic. Around 3/4 also reported at least partial disruption to school and workplace mental health services. These are very critical findings. Many countries have adopted telemedicine and teletherapy to overcome these disruptions to in-person services. So we are also practicing telepsychiatry as per the guidelines provided by Enhanced Indian Psychiatric Society and Government of India. But there are significant disparities in the uptake of these interventions. What WHO found out that more than 80% of high-income countries reported deploying telemedicine or teletherapy to bridge this gap in mental health, whereas only 50%, it is only 50% in the low-income group countries. As COVID pandemic is here to stay for next few months or even for next few years, we need to gear up our resources for the treatment of mental health requirements in the community. And things are moving back towards normal with the reopening of colleges, reopening of medical college OPDs, reopening of the services, emergency services, reopening of local public transportation. People are now attending the OPDs, but with people still suffering from COVID-19 infection and developing their complication, or even people are dying, their family members are not able to uh, see them after death, and they are being cremated. So that gives a long-lasting impact or trauma on the family members. So we need to address those issues, and I am very hopeful that we, as a psychiatrist and mental health expert, we rise up to this challenge. That is all I had to say. So over to Wadve sir again. So thank you.
Thank you, sir, for coming in as a reserve batsman and playing so well an inning. Thank you very much. I think since we are running out of time for three great speakers, I think we'll have quick question answer session, which will last not more than 12 to 13 minutes. We can have questions now to the first speaker, Dr. Amrit, and the other.
Arnav, how to see the questions posted by the participants?
Ostada, if the
Actually,
initial, sir, I have a small request, Dr. Wadve sir.
Sir,
I have to, because we have to drop my daughter, sir. If the first question, whatever questions are coming to me, if I can
Sure,
take it.
sure.
please.
Sure. Arnav, are you there?
yes, I am there. I am just
How to-
asking the technical person to share the link. So through the link, we can see the questions.
Yeah. Are there any questions? He can also.
Actually,
He can also-
one, two questions are there.
In the Facebook, we have reached 147 people right now. 147.
I think he can also direct the question to us rather than sharing the link, because that will create further delay. He can just read out the question.
I think Amrit wanted to say something. Amrit?
Yeah.
Well,
Sir,
Amrit, what about the patients? What about the patients who are having the raised aminotransferase level, liver function test raised to prescribe the melatonin in those cases?
so melatonin as a, so if you are giving remdesivir, that is again an issue. Now we are talking about interactions where the patient is in little higher, moderate to severe COVID, and he's having complications, and we need to state remdesivir, and there is a raised, remdesivir itself is caused a raised liver. We after the first dose also we see a lot of so melatonin low dose 3 to 5 milligram I think is good enough. Because some of the books, if you look at algorithms, you'll be astonished. They're recommending 50 milligram BD, 100 milligram BD of melatonin.
Arnav, please mute yourself. Arnav, please mute yourself. Yes.
Not only remdesivir, Amrit, ivermectin is used very much. It is also raised the liver isoenzymes.
Yeah, but 3 to 5 milligram is relatively,
Safe.
It will be safe.
fair enough.
Yes.
You have mentioned about the remdesivir and use of melatonin, and in your presentation you have mentioned about the high dose melatonin. So how much maximum dose of the melatonin can be used in COVID patients?
Like if you look at the algorithm for melatonin, it is given 50 milligram BD to 100 milligram BD. Even if you look at my presentation, for health professionals, it is 30 milligram per day.
Okay, I got some question. May I ask the questions?
Yeah.
Question asked
Sir,
by
can you see the link? You can get the question.
Yes, I got the question. Dr. Dhawale asked Dr. Dhawale from Mumbai asked a question. Should we give melatonin like vitamin C to everybody? Amrit, should we give melatonin like vitamin C to everybody?
Like I told you, it helps in improving the immunity. It helps to improve the antioxidant property. It helps in, so again, it's a call you have to take. It's an adjuvant treatment. Now we believe in miracles. कि थाली बजाने से कुछ हो जाएगा, कि कहीं कुछ करने से हो जाएगा. Plasma therapy. If you look at plasma therapy, everybody was talking about plasma therapy. What have you done? I have taken plasma. Suddenly, if you look at ICU doctors, people who have been treating COVID, they tell it's nothing, anything, and then it has been taken out of the drug. So as an adjunctive treatment, as a placebo, maybe as a means of making you feel good, no, we can always use it because it has no actual side effects except for a little bit of drowsiness and fatigue. So maybe it's our call. I won't suggest or I won't discount the fact, but maybe we can add 3 milligram of melatonin to people who are very anxious, very stressed out, who are susceptible. Even if you look at healthcare workers, they are anxious, they are susceptible, don't having proper sleep. So melatonin 3 milligram might just help in boosting their immunity, boosting their mental strength, as well as giving them proper sleep.
Dr. Amrit, can I share my experience a bit for a minute or
Please.
so? Yeah, because I am now a COVID survivor. I developed COVID infection on 1st of October. And on the 2nd, I was instructed by my brother-in-law, who happens to be a public health expert, to take melatonin 5 milligram every day, starting from day one of the infection. I didn't take that actually. However, I landed up with severe infection and received remdesivir injection for 10 days with the hospital admission. But what is happening after listening to your presentation with the role of melatonin, because I didn't know about melatonin that time or read about melatonin that time. So, but after listening to your presentation, now I thought that I should have taken that. And after COVID, after coming from the hospital, my sleep cycle has been severely jeopardized. Now I am having intermittent awakenings at night, and I am not able to sleep beyond 5 hours. My sleep is definitely, I am getting awake after 5 hours, invariably in the morning. So that is happening, and that I am just stressing the fact that probably because some experts are advocating the use of melatonin now, along with other things, but not for prevention, probably not for prevention.
Yes, yes.
After you contract the infection,
Post COVID,
yeah,
and
yeah,
during the COVID.
during the COVID, yeah.
Yes, thank you, Gustav, for input. I think that we can just leave the Dr. Amrit Parjoshi. He has his personal.
Yeah, I think we can.
Yes.
Excuse me.
Amrit, thank you very much for joining us. Take care of
Thank you.
yourself and have a nice Sunday. Thank you. Two more questions
sir.
are there in chat box. Two more questions apart from few congratulatory remarks given by Dr. Mukesh Jagiwala sir and others. The questions are, there are two questions. First question is asked by Professor Srinivas Murthy sir. Professor Srinivas Murthy sir has asked that could the panelists and members share their experience of utilizing the spiritual resources of India in general and West Bengal in particular to address the emotional aspects of the pandemic. So spiritual resources to address the emotional aspects of the pandemic. So I think myself and Dr. Kaustav will answer that. So the spiritual aspects of emotional aspects are very important. As we all know that the spirituality, the meditation, the yoga, these have been significant outcome and significant proven efficacy to relieve the stress. Lots of study had been done in the NIMHANS itself, and Professor D.N. Gangadhar has a landmark study about this, the role of yoga in our various psychiatric illnesses. So there are till date no studies systematically has been revealed that the COVID-19 related stress with the yoga and other spiritual experiences. But in our day-to-day experiences, we are seeing that obviously there's some meditation do work, but meditation alone cannot do anything, because if you just practice the relaxation, deep breathing exercises, or Jacobson progressive muscular relaxation without taking the appropriate precautionary measures, hand washing and wearing the mask, exercise generates a good neurochemical which is known as endorphin, and it's a feel good factor, and it causes a positive kind of addiction to go on keep exercising. So exercising controls our many vital functions, and also the lung capacity, tidal volume are also been found to be increased with the regular exercises. So spirituality is also obviously is a very important issue. The transcendentation, the going to the increasing the level of the threshold of our tolerance. You know, one of our Maharaj in the Ramakrishna mission who had amputation in his limb following poorly controlled type 2 diabetes mellitus with a gangrene in the lower limb, and he couldn't be anesthetized due to the various comorbidities and the cardiac dysfunction. But with the transcendentation and meditation, he had been amputated without giving any general anesthesia. So he can control, he can transcendent and meditate and keep his pain threshold above the level of the suprachiasma. So these are the techniques that we can practice and we can learn. Similarly, the spiritual and emotional experiences are very important aspects to control, because as we all know, psychiatry is not the primary subject of interest. During our childhood days, when the Ramayana and Mahabharata of the Ramanand Sagar and B.R. Chopra, probably the only entertainment and only colorful entertainment was broadcasted in the Chitrahar on Wednesday, there had been a tagline that there is little bit of steel in everybody's life in the advertisement of the Steel Authority of India Limited sale. So I'd like to reframe that phrase that there is little bit of psychiatric problem in our everybody's life from womb to tomb, across generation in both sexes, we can encounter these problems. So spirituality has a very important role to play. The second question, I would like to throw this question to Dr.
Ranjan, because of time constraint, I think we should stop here.
Okay.
That question, because our panelist and Dr. Vadve sir has his
Yes, sure.
engagement. Okay. So on behalf of the IPS West Bengal State Front, I would like to thank all the speakers, both the speakers and Dr. Vadve sir. I would like to request Dr. Vadve sir to say a few concluding statements regarding this discussion. So hand over to Dr. Vadve sir, and after Dr. Vadve's address, so we will conclude this session today. Dr. Vadve sir.
Yeah. Really, boss, I enjoyed the session. This breakfast samvad or subah ka khana, subah ka nasta ke saath jo tha. So there was a lot of scientific material. I really enjoyed right from Amrit. Honestly, as you said, I was also not aware of so much use of melatonin, which can be done by us in preventive as antioxidant and whatnot. Then Ranjan Das was an excellent presentation. Right from I told you, right from the
Ranjan
spectrum of
Bhattacharya.
neuropsychiatric disorder. Yeah, and in the end, he also told us about the iatrogenic factors. That I enjoyed, that I really learned most, because left, right, and middle, we are using the antiviral drugs, but we are not aware so much. As I became today, I was not aware that much of the side effect. And he also gave us, in the question answer session, told us and stressed the importance of spirituality and the exercises in the role of managing the COVID-19 pandemic. So, in all, excellent breakfast session. I enjoyed a lot. I thank you very much, and thanks again for asking me to chair this. I'm thankful to IPS and IPS West Zone State Branch. Thank you very much. I think we conclude here unless there is a vote of thanks from the Secretary. Thank you.
Yes. Thank you, everybody.
Thank you, sir. Thank you for being with us.
Thank you. Also, those who hadn't had their breakfast, please have your breakfast. Thank you all.
Thank you, Sikumadja, Kaustav, and Ranjan for organizing this.
Namaskar, sir.
Thank you.
Thank you, sir.
Thank you, sir.
Ranjan, I will borrow your
Amrit,
slides.
thank you.
Borrowed
Sir, thank you,
right?
sir. Thank you, sir.
Thank you. What you are telling?
I would like to borrow your slides. I will not use it.
Yeah, sure. I am sending this slide to your email. Don't worry. Thank you, boss. Thank you. Bye-bye.
Same request for Amrit also.
Sir.
Sure.
I will send it.
If you do not have any problem, then we can share this slide to our PGT group.
Yeah, sure.
Can I share that? Yes. Thank you.
Okay. Thank you. Have a good day.
Good day.
Thank you.
Thank you. Same to you, sir. And wish Dr.
Yes, Nambi, sir.
Nambi's
Nambi, sir.
speedy recovery after this meeting.